Okay, we got Alan Reynolds, my fellow again, who's interested in showing us his elbow. And so we're going to go over physical exam of the elbow now. This will be live. Why don't we start with whoever's the last one to sit down? That's you, Tom.
It would be me.
Yep. Tom, tell us, let's just start with not as much history taking because we're going to do that in cases, but what is your approach to the physical exam and the throwing elbow? Do you have a system that you go through? Do you start it a certain way? And so walk us through your initial exam, and then we'll get the other guys to give us some pearls as well.
Yeah, and I know we're doing history later, but I 15-second plug here. With a good history, obviously, most of the time, you may not know the exact diagnosis, but you've got a real good idea what few diagnoses are possible. So, physical exam, obviously, just like any other body part, initially would just be inspection. So if there was ecchymosis, that may obviously signal something acute happened. But look at the skin, and then for me, first thing I'm gonna look at is range of motion. I'll typically, obviously everybody's different, right? So some people have 15 degrees of hyperextension of the elbow, some just go neutral. So I'll start with having them, flex completely up. You're gonna check both sides, and then extend. And usually for extension, sometimes I find it a little hard just looking at them, so I'll literally go, side to side. So he's got about, 5 to 8 degrees of hyperextension here, and looks, pretty similar here. You can next do elbow range of motion is fairly simple. So you got flexion, extension, and then pronation, supination. So you usually have arms at the side. Supination, obviously palm up, pronation, palm down. So that's range of motion. Next for me would be palpation, and obviously this is usually somewhat again driven by your history. I mean, if they've got medial sided pain, I don't know that I'd spend a ton of time laterally, but laterally, epicondyle, look for tenderness there. Go distally, that's going to be radiocapitellar joint. Sometimes to accentuate radiocapitellar, I'll kind of pronate and supinate them. While I'm doing that, you want to palpate for crepitus, and then also see if that elicits any symptoms. Moving posterior from the epicondyle, your LUCL is going to be in here. Fairly, it's not really a throwing injury, but you could see somebody that had like a hyperextension injury, kind of elbow dislocation mechanism, so they could have tenderness over there. Also, muscle. So you've got your extensor muscle right here. We talked some about PIN and radial tunnel syndrome. So that's going to be distal and kind of anterior. So they were going to have pain kind of in this radial tunnel region here. And then medial side. Obviously you've got your epicondyle.
Tom, before we go to the medial side, do you have an exam maneuver for radiocapitellar plica?
No, I don't. Anybody else have a lot of times, if I've seen it real prominent, a lot of times the patient will kind of be able to move their elbow and create popping. I'll be honest with you, I'm not sure I've ever paid attention to exactly how they're doing it, but they'll literally say, here's what it's doing, and they'll create an audible and palpable pop.
It's usually flexion and pronation, and you can get a click, and then sometimes if it's anterior, if it's posterior, you get it with supination and extension, and it'll be an audible, palpable click. And again, we have to correlate if that's part of their issue or not. And what about tennis elbow? Do you have an exam besides tenderness? Do you do strength testing at their digits and wrist?
So provocative, I was going to do palpation, then provocative. But provocative testing for tennis elbow, I usually have them in full extension, have them actively dorsiflex their wrist, and then have them resist against me, and then that should create pain at the lateral epicondyle. In theory, I don't know how much I believe this test, but in theory, with radial tunnel syndrome with PIN, they should have pain. Spread your fingers a little bit. Pain with resisted long finger extension, but I don't know. I find that people with tennis elbow, that hurts them too. I don't know what
completely.
your opinion is.
Yep. All right, keep going, and then Jeff will jump in and talk to us about how to examine the ulnar nerve after you do some
Yeah,
of your
sounds
medial
great.
elbow exam.
So then medial palpation, epicondyle would obviously be where flexor pronator tendon inserts. And as was nicely shown by Chris for UCL, it's not right on top of the epicondyle here. UCL is going to be kind of the anterior-inferior aspect of the epicondyle. So tenderness right on the epicondyle would be flexor pronator tendon, or in a kid that could also be medial epicondyle apophysitis. And then UCL is going to start anterior-inferior and then extend down to sublime tubercle. So this would be kind of pain with UCL.
I like that palpation. By the way, it's and tell us, how hard do you push on somebody's UCL? But you can palpate epicondyle. You got a young kid, you can push on the epicondyle, see if they have apophysitis, and then you start marching down. And when you get, say, comfortable with it, you can tell if they got a distal UCL problem or a proximal UCL. And also the nerve is close to the UCL, so sometimes you're actually palpating the nerve. So how hard are you pushing?
Reasonably hard, I think. One nice point, I think Lee made the point yesterday when we were talking about shoulder, you have, in theory, a normal contralateral elbow. So if you're, let's say I'm just pushing really hard, and he says, ooh, that hurts, I can go to the other side and push with the same amount of force. And if he said, oh, that feels the same, obviously that means that probably not tender, it's just me pushing too hard. But you have a normal elbow, so always take advantage of that. But I push reasonably hard.
So pre-op, you push as hard as you can. Post-op, you just touch it.
Right. Post-op, I'm like, oh, that feels great.
Yeah. I in fact, every February 12th, 13th, and 14th get raging epicondylitis because spring training, you examine every part of their body, and they just come player after player in spring training. I get my own epicondylitis from all the
neck pain, shoulder pain,
yeah.
Back pain.
Okay, before we jump, well, let's do some ulnar nerve, and then with Jeff, and then Keith will talk to us about some other subtleties of the UCL exam with moving valgus stress test and things like that, and a posterior exam.
So one thing I think we all would say about examining anybody is try not to do the thing that hurts the most first, because it confounds everything else that you do. So if your history leads you towards the UCL, stay away from that to start with, because once you get them sore and hurting, number one, they may not trust you, and number two, everything might hurt, and then you're not really sure what's working and what's not. So the ulnar nerve, as Chris showed, is posterior to the medial epicondyle, or should be. Sometimes you'll see people, they have anomalous UCL. I've seen people without a history of an injury and their ulnar nerve is auto-transposed. Without a surgery, they've just flipped up there and stayed up there. So the ulnar nerve should be back here behind the epicondyle. And in most throwers, they don't have beefy, huge upper arms. They're pretty muscular and slender. And you can palpate the nerve above the medial epicondyle. You can actually feel it sometimes all the way several centimeters up above the epicondyle. And you can definitely roll it around in the cubital tunnel, but it should not be able to jump. You shouldn't be able to get behind it and roll it forward over the medial epicondyle. If it does, that may be what they're feeling. They may be feeling, and sometimes you can even see it. We've probably got some videos where people are moving their elbow through flexion and extension. You can see the nerve jump forward and backward. So those are pretty obvious ones. But if you can roll that nerve, and in him I can't, and you shouldn't be able to. If I can roll that nerve kind of up over the epicondyle, that's too unstable. It shouldn't be able to do that. And then obviously testing the muscles in the distribution of the ulnar nerve, the intrinsics. You can look at their hand and see if they've got wasting. Those are chronic conditions. So if you see somebody that's got wasting of their first dorsal interosseous, this is not a new problem. This has been going on for a while. People lose the ability to separate their fingers. That's a more chronic condition. Most throwers, a lot of them will report whether they had it when they first had their injury. They may say, oh, I had a little bit of numbness and tingling when it first happened, but nothing since. If you sit there and do a Tinel's test where you tap posteriorly on the ulnar nerve, and eventually you may get them to say that. If you push hard enough on that thing, if you really want to create an ulnar nerve symptom, if you sit there and really push on that nerve long enough, they're going to say, oh yeah, that hurt, I feel it in my fingers. I'm not sure that's necessarily a positive test. I could probably create ulnar nerve symptoms in everybody in here if I pushed hard enough. But what you're really trying to get from them is, do they feel it? Have they ever felt it? And do they feel it with just something light like tapping on that nerve? That should not generate a ton of ulnar nerve symptoms. And then you got to ask them, do you lay on it? Do you feel it when you lay on it? Do you feel it when you put your arm down on your car, on the console of your car, on the side, when you're sleeping at night? Do you wake up with it? So you want to make sure that the range of motion is full, and you want to palpate that. And you want to also ask them, where do you feel the symptoms? Some people will start feeling it as proximal as up here in the flexor mass, because the ulnar nerve does supply some of that area. And then some of them will just say, oh, it's just the tip of my fifth and half of my fourth finger. And it's a very specific distribution that the ulnar nerve covers. You'll also get people that'll say, yeah, I get tingling in my fingers, but you got to ask them which fingers. Because if they tell you they get numb in their median distribution, that may be more indicative of a different kind of problem. So I always want to ask them where they feel it when I do those things.
Yeah, great stuff. On what Jeff's referring to is the nerve jumping. We use the term ulnar nerve subluxation. And if you are able to roll it on the epicondyle and you can flex, you can keep it there. And then if you extend it, you'll feel it snap back into position. Sometimes that snapping is their symptom. That's their problem. They have a subluxing ulnar nerve, and then they get neuritis. That means, they get sensations into their finger that are uncomfortable for them. And that's a very treatable problem. Usually conservative treatment doesn't help it because it's going to snap no matter what. They may resolve the symptoms. I will say there's some players who have subluxing ulnar nerves that are asymptomatic, and it's perfectly okay for them. And Jeff said it subtly. We'll talk about it more. If the nerve is out of position, I take pause because there's things about needles going in there, palpation work,
Scopes,
scraping, all the stuff that we do in the treatment room. And then if you put a camera inside and the nerve is not where it's supposed to be, injure the nerve and or an incision to do, say, a ligament reconstruction. So we always do a nerve pause. Everybody, we palpate the nerve, and I usually keep my finger on the nerve anytime I got a scalpel in my hand. So, okay, that's good.
One other thing I'd like to mention, I hope that Kevin and Mike and David and the other people this afternoon will talk about this. I've gone to examining the shoulder and checking their range of motion in the shoulder anytime I have an elbow in a thrower first. And I hope those guys will show you how they do that, because it's a very specific thing. But I'm seeing probably close to 50% of the people I see for UCL problems have some loss of shoulder rotation that's significant. So I think that's something that may be seeing us that we're not paying enough attention to, and maybe that plays into some of the nerve stuff we see as well.
Jeff, one last thing. That we think of nerve pain, neuritis, cubital tunnel syndrome, and throwers get this frequently. Do they ever get nerve pain without the paresthesias or the sensory motor component to it? Can they just have pain in the area of the cubital tunnel that maybe radiates a little bit?
They can, and ulnar neuritis can present as either, the symptoms of the nerve itself with the numbness, tingling, or it can be pain. It's typically not pain in the fingers; it's typically pain at the nerve. But if that's going to be the case, it is typically going to be that posterior in the cubital tunnel type of pain. Sometimes that's hard to ferret out from a flexor pronator thing because they overlie each other. It's one of those confounding things when people have pain, but they don't have the typical neuritis symptoms, but it is certainly possible. EMGs, and I'm giving the talk on this in a little bit, EMGs in throwers are typically negative. We get them a lot, but they're typically not very productive. But maybe they're a little bit more productive in those who just have pain and don't have the numbness tingling. I don't know. I don't have that data, but you do see some people that just have pain from ulnar neuritis.
Yeah, I see it too, and it's a hard diagnosis, EMG nerve conduction studies, which we can talk about when they're indicated and when they're not. You don't have a lot of supporting imaging or testing to help with that diagnosis. So again, physical exam is critically important. And as Hollis Potter said yesterday, the MRI report on the ulnar nerve is always that there's some characteristic that we can call abnormal. So it's kind of normal abnormal. It's got signal around it, but everybody's got signal in their ulnar nerve. Keith, do you want to make any more comments on the ulnar nerve, and then tell us about how you go to the posterior elbow and the UCL?
Yeah, just a couple quick pearls for me. I believe that a physical exam should be very, very regimented. And that means from top to bottom, you do the same thing every time, irrespective of our presumptive diagnosis. And I think everybody would agree with that. And I always start at the top and I work down. So I always start actually patients standing, and then I have them sitting, and then I have them supine, and then sometimes prone. And I go through that every time I examine an elbow. And because 95% of the time the diagnoses that we see, and everybody will agree, we've got our diagnosis probably on history alone. But the zebras, the subtle things that also oftentimes contribute to, if we are not regimented, at least in thought process when we're doing these exams, we're gonna miss the little things that hopefully make us a little more expert in taking care of these guys. So I start, and I actually have a goniometer in my pocket. I'm extremely obsessive about documenting range of motions. And I do always get full shoulder range of motion, IR, ER, flexion, both sides, side to side, so I can document that, and hopefully that contributes or doesn't to pathology. And with the elbow, I'm always standing actually along the side, and I'll have them out front, extension, and I take the measurement, because if I'm operating on this individual, I want to measure the guy post-operatively if he's having motion problems. The other thing that we don't talk about is the shift in pronation, supination arc that we see in these individuals as well. And I don't know what the contribution of that to pathology may or may not be, but just like in the shoulder, we have supination on the dominant side is usually less than supination on the non-dominant side. And then pronation is oftentimes increased side to side. Again, I've looked at this for years, and I don't know objectively or subjectively, I should say, that I can say that it is pathologic in any way, but it is a shift in rotational arc that we see. And I haven't gone and measured all these things from a bony anatomical standpoint and soft tissue, whatnot. So again, I start standing, and then I sit, and that's when I do my measurements, and I do my shoulder resistive stuff, and then work down to the elbows, and then I have them supine. So you go ahead and lie back flat, clear the deck again. And from my supine position, I start the non-dominant side, and I go shoulder range of motion first, elevation, then the IR, ER arc, and then I work myself down to the elbow. And for me, again, I always feel like I can get the patient much more relaxed in this position when I'm doing all my provocative maneuvers, particularly on the medial side of the elbow. So for me, medial side and posterior side exam, I usually start medial and then work backwards. And these guys have already gone through the palpation of it, but you can see the medial epicondyle. I don't know how well you can get out of your way here. Medial epicondyle, and again, I always start just subtly off the distal edge of the medial epicondyle for the proximal bundle, the medial ulnar collateral ligament, and the detailed anatomy of this we don't talk about. We talk about the distal UCL. We don't talk enough about the anatomic footprint proximally and actually where that UCL comes off of, because I think that's far, far more impactful clinically and during our reconstructions than the distal footprint. I think we have a lot more flexibility distally. I think proximally is where we oftentimes may be making our mistakes, you know, surgically and otherwise. So I start proximally, work distally. You can feel the sublime tubercle. Obviously, the nerve is inherent in a critical part of your exam on this, and Jeff has done that nicely. And then on the posterior side, I'll slide or lie on the posterior medial joint line, feel the olecranon tip, feel into the olecranon fossa, come up the tricep. A lot of posterior compartment symptoms are kind of referred tricep pain. A lot of guys will come in and say, my tricep is sore. But really what it is backsided elbow stuff, whether it's degenerative or just a spur or an over-constraint of the joint in a post-operative UCL. One of the most common complaints, and the trainers can speak to this, and the therapist, when they're in their throwing program early on, is this backside posterior elbow pain, or they call it tricep pain, but it's really, I think, probably an over-capturing of the joint before that joint becomes whippy again. And then for me, my exam, I like to get into the axilla here, and I fully supinate the forearm, and in this position, I can lock in the shoulder, and I can valgus the hell out of this elbow. and you can feel how your shoulder's locked in, so my elbow and my forearm isn't spinning at all. A lot of guys like to do this in a sitting position. I've just never been able to recreate this in a sitting position. So supine, external rotation in the shoulders, supination of the forearm, and I will go to full extension, and I can get them in a flex position, and I feel like I can be very objective and very accurate in my assessment. Now, side-to-side differences, hell, man, I can tell you something. I'm not sure I can feel a couple millimeter difference, which is often at times a very much a game changer in terms of exam. Sometimes it's more qualitative than it is truly something that I can feel like it's quantitative. And then from this position here, I'll do my moving valgus stress test, or what I call the O'Driscoll maneuver. The tip of the hat to Sean, who thought about this years back now. And I'll start actually in a pronated position. I like to put them in the cock position of throwing, so to speak, and I will stress them in valgus in this position, and I will move them through the arm position that technically they're going to have while they're throwing a baseball. And then I move them into supination as well, which really mimics more the milking maneuver, so to speak, that guys talk about that they can self-do on their own, and see if there's a qualitative difference with that. Tightening up and relaxing, so to speak, the UCL and the medial soft tissue envelope, and see if there's a difference. I'm not sure that I've found consistently that there is a difference in that part of the exam, but I'm looking for subtleties. I think that maybe can help us in terms of making our decision from a clinical standpoint with some of the more subtle problems that we see with the ligament. And again, these things just go into the Rolodex, so to speak, and you see enough things, and all of a sudden you can begin to come to certain conclusions that perhaps before you had the experience that now you have. And then the one other thing that's worth noting is that the olecranon, and I know George is talking about paletta olecranon stress fractures, oftentimes that is difficult to differentiate between that and the ligament. It'll be a more diffuse achiness in the ulna than more focal discomfort on the medial side of the elbow. And so make sure we're palpating again along, not just when we get to the sublime tubercle, I'll shift over to the body, the olecranon, and come down and feel medially and laterally and see if I can palpate and find anything there that may be symptomatic on these individuals. And then lastly, I come into the fully extended position and I do the so-called valgus extension overload maneuver. I go straight extension first, which is the so-called bounce test, and then you can add valgus to that as well and try and reproduce those posterior symptoms. One last pearl on the back side of the elbow I find very, very helpful. And I don't know where and when I picked this up, but if they have a lot of degeneration in the back of the joint, meaning more degenerative arthritis, differentiating between perhaps posterior elbow impingement and an osteophyte, and degenerative posterior elbow is I actually take them into full flexion and I have them push, and I say take your hand here and hold it in this position. So I'm loading the posterior compartment of the elbow joint, and a lot of the times they'll say that's my discomfort, that's what I feel. And it's not just pain at release. And then I do it at 90, hold it right here. Symptoms aren't so bad. And then I get them in full extension, I resist them again. Now they really don't have any pain. But they have that posterior discomfort at release when they're throwing. And I think that's sometimes how you can differentiate between chondral lesions on the distal trochlea, or I should say the proximal trochlea posteriorly, posterior medially, and even laterally, versus just, say, an osteophyte that's impinging at terminal elbow extension. Again, that's just something I kind of dug up along the way. I don't know if that's something anybody else kind of has found in the training room and in your own offices and whatnot. But I think that's a really cool little trick that
Keith,
I found to be
that's
helpful.
fabulous. One more piece before we conclude, or any other comments. How about the flexor pronator exam?
Yeah, after I've done my posterior elbow UCL, then I come on, and again, they're still in a lying position, and I'll start them first with a flexed elbow position, resist wrist flexion, and then I have them come down into extension, resist wrist flexion, and I like to put my finger right on the tip of the medial epicondyle. And while they're resisting, they may or may not have discomfort. And sometimes I can differentiate maybe perhaps at this point, is this something more isolated flexor tendon or is it more proximal UCL? So I hold them resisting in that position, and that's when I'll really flex, because you can really feel along the flexor tendon at that point and slide down to the forearm. And then I have them actually pronated position, and I have them resist pronation as well. So those are the three maneuvers at the elbow. And then lastly, I'll actually have them, all right, ring little finger. I have them hold it, pull, 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 see if I can recreate symptoms. And then down in this position, pull, pull, pull. And usually I'm just about done with my exam. I have them sit up. And then the test that Jim Andrews taught me years and years ago, the forehead press test, or the temple press test, to kind of recreate those symptoms on the medial side that may be more flexor tendon. This for me is more flexor tendon. Oftentimes this may be UCL. So that little maneuver is actually oftentimes really, really helpful to differentiate.
That's great.
So,
That was fabulous. Yeah, thank you guys.
thank you.
Hey, can I ask a question real quick? Or not?
Hey,
Just not.
Tom went first, so he gets to go last. Go ahead.
I just want to ask a question. So Keith, you've made a good point of reminding us about nerve issues in the shoulder. Median nerve in the elbow, do you think that's common? If you think they have it, do you have any pearls for that?
Yeah, I think, again, with nerve issues, neurogenic problems in the throwing extremity, I start proximal. I think that every pitcher, and everybody hates to be labeled TOS, because it's oftentimes a black mark on their record. But I think every pitcher has some semblance, especially at the more elite levels, of neurogenic thoracic outlet syndrome. It just depends on how it presents. Some guys may present with lateral arm achiness, and they'll be tender over the course of the radial nerve. Some guys will be exacerbated in their extensor mass, and it'll be more PIN type symptoms, but I think it's a double crush phenomenon. And I always say, and I explain to the athletes, it's like standing on a fire hose. I mean, you stand on it at the top, you stand it at the bottom, but you're not completely occluding in either place. And if you can mitigate one of the two. Now obviously with the median nerve, you can get obviously compression at the proximal forearm. They got something anomalous at the pronator, or just a tight pronator fascia, and they may be symptomatic at that point there. But again, as soon as they start complaining of neural symptoms to me, I'm always thinking here first. And so I'm always telling the trainers, work the scalenes, work the first rib, work their shoulder posture, those things that will help mitigate this first, but then we work down the neural chain, is how I look at it.
Yeah. No, because I know John Conway, we end up reviewing all these op notes when all the draft choices, and he seems like he does a fair number of these median nerve releases at the elbow. I don't know if I'm just missing all of these. I haven't seen it. So I just didn't know if you guys
exactly
have any
my
pearls.
point. That's exactly my point. I think it starts proximal. I've done one in my last 20 years. I've done one median nerve release, one, and my practice is 98% baseball players.